fix it on time. So anyway, so our last speaker for this, for the first half of our session is Maricar Malinis, a very fitting name for an infectious disease specialist. Maricar, I believe, heads the COVID treatment team at Yale. So she's going to update us on the evolving treatment approaches to COVID-19.
Thank you, Vince. Good morning, and I want to thank Vince Faustino and the organizers for giving me the opportunity to give this talk. So I will be discussing the evolving treatment approach to COVID-19, and day to day, there's always new data. So there's, even this morning, I have to make some updates to my slides. So I have no disclosures. So before I proceed with the discussion of therapeutic management, I will discuss briefly the clinical presentation of COVID-19, which has been slowly understood with time and clinical experience. It is theorized that the disease exists in two phases. The first phase is the viral response phase, and the second phase is the host inflammatory response phase, or otherwise called cytokine release storm, as depicted in this illustration. How does this translate to clinical presentation? So during viral replication, infected individuals may have mild constitutional flu-like symptoms with or without GI symptoms, and lab abnormalities may include lymphopenia, increased D-dimer, and LDH. The inflammatory response may manifest early with pulmonary decompensation with evidence of abnormal chest imaging, and also may present with liver enzyme abnormalities. Worsening inflammatory response is likely when there is pulmonary and extrapulmonary manifestation, including ARDS, systemic inflammatory response syndrome, shock, and cardiac failure, with notable elevated inflammatory markers that may include CRP, LDH, IL-6, D-dimer, and ferritin. Awareness of this pathophysiology and clinical staging of COVID-19 can assist in the clinical decision-making with regards to choice of therapeutics or intervention. So antiviral therapy is preferred to be given early in the disease course, while immunomodulatory agents have a role once the patient hits the inflammatory response. At present, there's no US FDA-approved treatment for COVID-19, and supportive care is considered the standard of care. So in response to the pandemic, the Yale School of Medicine and Yale New Haven Health Multidisciplinary Treatment Group produced a standardized treatment approach to the management of hospitalized COVID-19 patients. In this treatment algorithm, which has been frequently revised based on the most up-to-date clinical data, local clinical experience, and expert opinion by a multidisciplinary group composed of specialists in infectious diseases, pulmonary and critical care, rheumatology, immunology, and hematology, and of course, our reliable pharmacist. This treatment algorithm, as mentioned, is specific for hospitalized patients with confirmed SARS CoV-2 by PCR and requiring oxygen supplementation. So patients who meet this criteria will receive both remdesivir and dexamethasone, or its steroid equivalent, and tocilizumab has been added as a rescue drug. Rationale for this use will be discussed later in the talk. So in addition to the treatment recommendations, we also recommend routine lab monitoring and EKG to assess renal, hematologic, and cardiac complications respectively. Of note, we have also given recommendations of anticoagulation and aspirin because of the observed increased thrombotic complications in these patients. There have been several agents that have been suggested to have in vitro activity against SARS CoV-2 based on either prior data with MERS and SARS CoV-1 and through computational science. Of note, atazanavir, a protease inhibitor that was previously included in our algorithm, was removed once the New England Journal of Medicine study revealed that lopinavir-ritonavir, which is a protease inhibitor 2, was shown to have no difference in the clinical improvement or mortality when compared to standard of care. Some of the mentioned drugs here have limited clinical data to assess their efficacy. Camostat and favipiravir are currently being evaluated in clinical trials. Today, I will discuss the therapies that have clinical data that defines their role in the management of SARS CoV-2. So first, I will address the most controversial drug, which is hydroxychloroquine and chloroquine. So chloroquine is a known antimalarial drug that has in vitro antiviral effect against novel coronavirus that inhibits viral entry via ACE2 receptor and prevents acidification of endosomes, therefore interrupting cellular function and viral replication. In addition to the antiviral effect, it was speculated that it may have an immunomodulatory benefit by attenuating the cytokine production and inhibiting the lysosomal activity in host cells. Early small studies during the pandemic supported the use of hydroxychloroquine by demonstrating higher rate of viral eradication, shorter time to clinical recovery, and radiographic improvement. However, more recent randomized controlled trials have shown no clinical benefit of hydroxychloroquine when compared to standard of care. The recovery trial in the UK have shown no 28-day mortality benefit when compared to standard of care. The ORCID trial that was sponsored by the US NIH was stopped once preliminary analysis revealed no benefit of hydroxychloroquine compared to placebo. And a recent study also showed no benefit of hydroxychloroquine in mild cases treated in the outpatient setting. Another concern with hydroxychloroquine is the QTc prolongation and possibly cardiac arrhythmia when used in combination with azithromycin, as demonstrated by the study of Borba in Brazil. The US FDA, who initially issued an emergency use authorization for hydroxychloroquine, has to withdraw this authorization. And the NIH and the Infectious Disease Society of America guidelines do not recommend its use outside of clinical trials. One of the promising therapies from remdesivir, which is a nucleotide analog that binds to viral RNA-dependent RNA polymerase and inhibits viral replication. It was initially developed in response to the Ebola outbreak in West Africa and has in vitro and in vivo activity against MERS and SARS-CoV-1 and in vitro activity against SARS-CoV-2. The Act1 Study, which is an NIH-sponsored study, involved 60 sites, published the results recently in New England Journal of Medicine. In this study, 89% enrolled were considered to have severe disease, which meant requiring some form of supplemental oxygen. There was shorter recovery time overall in those patients who received remdesivir compared to placebo. When further analyzed based on baseline ordinal scale of clinical severity, those who were on supplemental oxygen had the greatest benefit from remdesivir. This study showed some trends towards improved 14-day survival in remdesivir arm, however, it did not reach statistical significance. Based on the result of the ACT study, the US FDA issued an emergency use authorization for remdesivir, and the US federal government allocates remdesivir to the states based on the number of active COVID-19 cases. The immune dysregulation and the exuberant immune response in SARS-CoV-2 has been shown to cause lung damage and overall poor outcomes. Target immunomodulation can ameliorate the cytokine storm, pulmonary inflammation, and may improve overall survival rate. There are several drugs that were speculated that can attenuate the hyperinflammatory phase of COVID-19. Currently, the NIH and the Infectious Disease Society of America guidelines have emphasized that there is lack of clinical data to recommend these listed agents, and it's preferable that these agents are offered in a clinical trial study. More recently, the sarilumab clinical trial in the United States, sponsored by Sanofi and Regeneron, was stopped after the drug failed to prevent deaths or get patients off ventilation, which were the study's key endpoints. More so, patients treated with sarilumab was found to have severe side effects, including shock and multi-organ dysfunction in 3% of enrolled subjects. Now, IL-6 is a cytokine secreted by monocyte and macrophage that appears to be the main driver of immunologic response and symptoms in CRS based on early case series of COVID-19 in China. Now, tocilizumab is a humanized monoclonal antibody similar to sarilumab that inhibits membrane-bound and soluble IL-6 receptor and has been approved for rheumatoid arthritis and cytokine release syndrome related to chimeric antigen receptor T cell therapy. A small study from China reported that 21 patients who received tocilizumab had fever resolution, decreased oxygen requirement, improved chest CT imaging, and inflammatory marker profile. In our institution, we included tocilizumab in the treatment guideline because of some clinical data and its safety profile based on the experience of our local hematologists who have given tocilizumab for cytokine release syndrome after CAR T cell. The data collected was during the first 3 weeks of the COVID surge. We evaluated survival and mechanical ventilation rates at 14 days. During this course, we have shifted from giving tocilizumab in critically ill patients to giving it early when there is increasing oxygen requirement with rising C-reactive protein. Note that the graph on the right illustrates our mechanical ventilation rates that have been stable despite increasing number of COVID cases. The survival of patients with severe disease who received tocilizumab was similar to the non-severe cases. As one of my colleagues have said, the tocilizumab seemed to be the equalizer. Randomized controlled trials of tocilizumab are still ongoing, but this morning, preliminary results from the COVACTA trial, which was sponsored by Roche, was released to the press. The trial was a randomized controlled study of tocilizumab versus placebo in the treatment of severe COVID-19. The primary endpoint of the study was 28-day improvement in clinical status, which was not shown to be any different in patients who received tocilizumab compared to placebo. There was no survival benefit nor difference in the ventilator-free days of those who received tocilizumab compared to placebo. Although notably, the time to hospital discharge was shorter in the tocilizumab arm compared to placebo, but the authors commented that this is considered not significant since this was not, the study did not meet their primary endpoint. Final paper is still in the works and still needs to be peer reviewed. Now, steroids have been used in respiratory viral infection and has been controversial in general. The use of steroids in influenza had been associated with increased mortality. In the MERS and SARS CoV-1 experience, there was a decrease in delayed clearance of viral RNA from respiratory tract and blood, respectively. In contrast to other novel coronavirus, there was mortality benefit observed in the use of methylprednisolone amongst patients who were mechanically ventilated with ARDS per study in China. The recovery trial was designed to evaluate the effects of potential treatments in patients hospitalized with COVID-19 in the UK. And this was supported by their National Institute for Health Research Clinical Research Network. They evaluated the use of dexamethasone, 6 milligrams daily up to 10 days versus the standard of care. This graph on the right side demonstrates there's an overall decrease in mortality in the dexamethasone group. Based on the oxygen requirement at time of randomization, those who were on mechanical ventilation and oxygen experienced benefit from dexamethasone use. And this benefit was not replicated in patients not requiring oxygen supplementation. So based on the results of this recovery trial, the NIH and the Infectious Disease Society America guidelines have altered their recommendations and favored the use of steroids in COVID patients requiring oxygenation. One other treatment that has entered in the discussion is the convalescent plasma that has been used historically for other types of viral infection. So theoretically, antibodies to SARS CoV-2 may help suppress the virus and may modify the inflammatory response. This JAMA paper was published early in May that demonstrated the potential benefit of convalescent plasma use in COVID-19. Post-infusion of the convalescent plasma demonstrated that there was normalization of temperature within 3 days in 4 out of 5 patients. ARDS resolved at 12 days post-transfusion, and ventilator was weaned within 14 days in 3 out of 5 patients. Now, there's another randomized controlled study in China that was conducted much later in the pandemic and was not able to demonstrate any significant difference between those who received convalescent plasma versus control arm. The 28-day mortality and time to discharge was not different. Actually, the clinical improvement within 28 days was not any different between convalescent plasma and control. The 28-day mortality and time to discharge had trends that favored convalescent plasma. However, it did not meet statistical significance. When they did a sub-analysis of the severe disease group, they found that there was shorter time to clinical improvement within 28 days and higher rates of clinical improvement at 28 days amongst those who received the convalescent plasma. Note that this study was terminated early due to the lack of new cases, and the authors concluded that the study may have been underpowered to detect a clinically important difference. In the United States, it has been used under the FDA emergency use authorization. And per this paper published from Mayo, there was a low rate of serious adverse events among those who received convalescent plasma. The side effects included some transfusion reaction. Notably, the 7-day mortality rate was 14.9%. Clinical trials are still in progress, and we are still waiting for the results. So in summary, there's no approved drug yet for COVID-19. To date, clinical trials have supported the use of remdesivir as the antiviral therapy of choice and dexamethasone as the immunomodulator. Convalescent plasma may have a potential role in the management of severe COVID-19 pneumonia, and therapeutic options for mild disease in the outpatient setting remains lacking. And I want to acknowledge my colleagues at Yale School of Medicine who worked tirelessly during this pandemic, and thank you very much.
Thank you very much, Maricar. And thank you to all our last speakers. That was really excellent talks.